This is Chapter 7, Care of Patients with Pain. Lesson 7.1, Care of Patients with Pain, Theory Objectives. You have a whole host of objectives from theory, what you're supposed to learn about in lecture, like reviewing the gate control theory of pain and its relationship to nursing care, understanding how the gate control theory of pain applies to pain management. Discuss how the neuromatrix and central sensitivity theories help explain types of pain other than those arising from tissue injury. Demonstrate an understanding of the current view of pain as a specific entity requiring appropriate intervention. Compare nociceptive pain and neuropathic pain and nursing care for each. Explain how pain perception is affected by personal situations and cultural backgrounds, because we do know that your sociocultural background may affect how you perceive pain and how you want your pain treated, right? Okay. Analyze the major differences between acute and chronic pain and their management. We're going to do a lot of this in this lecture. Demonstrate the use of the nursing process when caring for patients experiencing pain. Give examples of the different pharmacologic approaches to pain that include, see here, woo, we lost our objective. Let's find it. Gotta love the Zoom guy, he gets in the way all the time. The use of adjunctive measures. So things like if you're giving an opioid, you're also giving an NSAID, you're hitting it from different sides, right? Okay. Clinical practice objectives. After learning about this in theory, we want to see you apply it to clinical in the following ways: that you're able to use appropriate pain evaluation tools and measures for a variety of patients, that you're able to recognize the common side effects of pain medications and describe techniques for addressing those side effects, that you're able to employ non-pharmacologic approaches to pain management for a variety of patients, and that you're able to demonstrate the use of the nursing process when caring for patients who are experiencing pain. So we're going to talk about pain theories, right? So pain, a general definition is it's a neurologic response to an unpleasant stimulus, right? Or unpleasant stimuli. We're going to learn a little bit about the gate control theory, okay? The breakdown, the very basis of the gate control theory is when the gate is open, pain can come through. When the gate is closed, pain sensation, the conduction of that pain impulse is blocked. So this is very similar to when someone has an ouchie accident or injury, right? And we distract them by causing pain somewhere else, right? If we're causing pain somewhere else, they're going to be distracted by the other pain and not as able to feel the pain that we're actually treating or that we're concerned about. Same thing with like a TENS unit. Have you ever used a TENS unit or seen one used?
No.
Okay.
No.
So these little electrodes that we put on an area where there is pain, and we send these little electric signals through the body. We stimulate an area, right? And the body, or the brain, excuse me, is so distracted by all of these signals that it's processing, all these vibrations, right? That it doesn't process the pain as easily. So the gate is closed because it's overwhelmed with processing other sensations. So I'm going to show you a quick video on gate control theory. I will tell you it's not my favorite video, but it is the best that I found at explaining gate control theory. Just really quick, nursing applications of gate control theory: activity in small diameter nerve fibers are usually able to open the gate, whereas activity in large diameter nerve fibers seem to close the gate. So let's take a peek at this video on gate control theory.
You're together. What's up, everybody? I'm Patrick Kelly, and today we're talking about pain. And I'm not talking about my dad never brought me to soccer practice when I was a kid kind of pain. I'm talking about real physical injury kind of pain. But to do that, I'm gonna need you to think about the last time that you got a good bump on the arm or a shinner, something good that left like a nice bruise. And unless you had immediate access to an ice pack, there's a good chance that you put your hand on the injury spot. Not because you needed to stabilize the injury, but because something in your brain knew that that would make it feel better. And it's true, putting touch on an injury site can mask the pain. But how does that work? And we'll get to that, but first, time for the big picture. Pain is just a sensation. You were probably taught the 5 senses back in primary school: vision, smell, taste, touch, hearing. Pain isn't on that list. That's because the idea of senses is actually kind of vague. They leave a lot of information out. But if we want to get a deeper look into what actually happens, we can study the physiology of the nerves that make up the anatomy of each of those senses. Your tongue and nose might be responsible for the overall sense of taste, but each taste bud is more specialized for a specific taste, like the taste buds for salty or for sweet. That's because they contain chemoreceptors, nerves that detect chemicals like the ones that give off flavor or smell. At the cellular level, these are highly specialized cells, but collectively, they make up the overall sense of taste. The same thing happens with the sense of touch. We can tell that a blanket is both soft and warm, or that a knife is both sharp and stiff. And it's all because we have different kinds of nerve endings in our skin that signal for different types of touch. And we can divide those into 3 categories. We have thermoreceptors that detect temperature, a bunch of different mechanoreceptors that detect mechanical pressure or distortion. When you think of the sense of touch, you're probably thinking about what these nerve endings detect. And just to give you an idea of how specific these nerve endings get, we have different nerve endings for low frequency vibrations and other ones for high frequency vibrations, some for sustained pressure and some for just tension in the skin. They're all really specialized cells that together make up our overall sense of touch. And finally, we've got nociceptors that send pain signals to our brain. Anytime we get a signal from one of them, we call that a noxious signal. Anything else is innocuous. If you've seen this diagram before, you're probably familiar with structures like the epidermis and the dermis, but never really knew that those mechanoreceptors were hiding in there the whole time. Now, that diagram is just the surface. That's the point where the outside world meets our nervous system. Each one of those nerve endings is connected to a nerve, but not all nerves are created equal. The nociceptors tend to hook onto something with a little bit of a thinner diameter, while the mechanoreceptors tend to have a thicker nerve. All right, let's assume for just a second that you get punched in the face. Immediately, those nerve signals are just signals. They haven't gotten registered in the brain as, hey, I just got punched in the face. That first part, getting punched in the face and then those nociceptors getting stimulated and sending signals to the brain, that's the process of sensation. It isn't until the brain picks up on what's going on and interprets it that you are now in the process of perception. Now your brain has made sense of everything and can say, hey, I just got punched in the face. And for something painful, those noxious signals travel to the thalamus and then to the somatosensory cortex to get interpreted a little bit further. And that pathway makes enough sense to me, but something stuck out while I was researching for this video. Specifically, how does your body tell what gets coded as pain in the first place? I mean, you can shake somebody's hand and it will be fine, but that same size hand can put a death grip on you, and that is painful. So then how does your body say, this is fine, but this hurts? Well, that's exactly what researchers Melzack and Wall investigated in their 1965 article in the journal Science. See, up until then, there were 2 main theories of pain: the pattern theory and the specificity theory. Now, there were other pain theories at the time too, but these were the ones that the research team outlined on their paper. Melzack and Wall looked for a way to tie together the pattern and the specificity theory, but also try to incorporate our own psychology and perception of pain. And that's where the gate control theory of pain comes in. Remember how earlier I was talking about rubbing injuries to mask the pain? Once you get hurt, those nociceptors send signals towards your brain so it can be perceived as pain, right? Here's what Melzack and Wall proposed. Any nerve signal could go to one of 2 in-between destinations while it's on the way to the brain, either to transmission cells that would pick up the signal and take it to the brain, or inhibitory interneurons that would make the activity less intense. For those interested, this happens in the dorsal horn of your brainstem in an area called the substantia gelatinosa. When just the noxious stimuli are coming in, they'll turn down the inhibitory interneuron, which lets them bust through the transmission cells on the way to the brain unhindered. And I know the wording can be a little confusing, so when we're saying saying decreasing the inhibitory interneuron, that's kind of like a double negative. So that's really meaning that it's increasing its ability to go through the transmission cells. Going back to the example of getting punched in the face, when you rub your face because it hurts, the nerves attached to those mechanoreceptors are actually increasing the inhibitory interneuron on the pain signals. And this is where they got the name gate control theory. Your face is still giving off signals for pain, but by stimulating those touch receptors, you closed the gate which kept the pain signal from reaching your brain. But you can also close the gate from the other direction. Gate control theory says that messages coming from the brain can shut the gate on noxious signals as well. So if you just stepped on a Lego because you were trying to save a baby from a burning building, you might not notice the pain until you knew that you were safe and out of the fire. And hopefully you returned that baby safe. Not every form of pain relief uses this pathway though. Medications and anesthesia use completely different paths. Now, obviously something super painful like a broken bone is going to overpower any mechanoreceptor stimulation. But for your minor bumps and bruises, it's nice to have some pain relief, and the gate control theory of pain offers that. Thank you for watching. If you learned something today,
What did you guys think about that video? Do you think that it adequately explains the gate control theory for you?
I liked it. I thought it was good.
Okay. So when a large volume of non-painful stimuli is competing for the gate, the pain impulses may be blocked. That's what we learned, right? A high volume of pain, however, may override other stimuli, like a broken bone, right? And pass through the gate, causing the individual to go ahead and perceive that pain. Massage and vibration will produce activity in the large diameter nerve fibers. And we know that the large diameter nerve fibers do what to the gate?
To close.
Close the gate. That's right. Okay, the next thing we're going to talk about is the pieces of pain theory. So this is something we use with the elderly, but also with children. So it's the idea that there could be multiple factors that cause pain, or that there could be, in the younger people, there could be multiple degrees or varying degrees of how the pain is felt, right? So we can do something like lay 4 poker chips out on the table in front of a small child and say to the child, tell me, how many pieces of pain do you have? And then it is our responsibility to understand, if they pick 2 poker chips out of our 4, whether that means that their pain is like a 5 out of 10 on our numeric scale, or if they have 2 areas where they're hurting, because it could be either. So we could ask those clarifying questions. Now, if there are multiple pieces of pain because there are multiple areas where the child or the cognitively impaired adult is experiencing pain, that means that there will be more than one treatment method, more than likely, right? The greater number of pieces will require a greater number of pieces of treatment to control the pain. And of course, the more intense the pain, the greater number of pieces they may pick. Endorphins. I'm sure we've all heard about those wonderful endorphins, right? Endogenous morphine. They can attach to pain receptors and block pain sensation. And so that's something to keep in mind. Endorphins are pumped out when we exercise, right? When he was talking about running into a burning building, you have endorphins. You also have adrenaline that may block pain sensation, right? Okay. Classification of pain. There are 2 primary categories of pain, and I hope you know this from reading chapter 7 in your book already. The first category is what, Brooke? Give you a hint. It's right here.
No, I can't read.
Nociceptive pain. Okay, nociceptive pain is pain that's associated with pain stimuli from either a somatic, like a body tissue pain, or a visceral or organ pain. So those are actually 2 branches inside of nociceptive pain. So nociceptive pain can either be somatic or visceral. Remember, somatic is going to be cutaneous, superficial, right? Like a skin or subcutaneous tissue pain. You could also have a deep somatic, which would be like a bone pain, muscle pain, blood vessel or connective tissue pain. These types of pain, the somatic nociceptive pain, are going to be sharp, burning, dull, aching, cramping, right? If a person has had a surgery, an incisional pain, a pain where they have a drain or a tube plugged in, an area where they have a wound, any kind of orthopedic procedure, or skeletal muscle tissue injury or trauma or inflammation or irritation can cause somatic nociceptive pain, okay? Additionally, somebody has bony metastases of their cancer, right? Or osteoarthritis or rheumatoid arthritis. If they have chronic low back pain, if they have PVD, they may have somatic nociceptive pain. Visceral pain, on the other hand, is related to the organs and the linings of the body cavities. So we're talking things like poorly localized pain, right? Abdominal pain. Oh, my belly hurts. That's a visceral pain, okay? It's diffuse. It's a deep cramping, splitting, sharp, or stabbing pain. Can you think of something that might be classified as a visceral nociceptive pain, Peyton?
Maybe like a stab wound, cut in the skin.
So a cut in the skin and a stab wound are most likely going to be somatic nociceptive pain because they're going to be mostly affecting the skin, subcutaneous tissue, muscle, and connective tissues, right? Now, if we go down into an organ, potentially we could have some visceral pain, but what would be more organ-based pain? Can you give me an example of visceral
Like
nociceptive?
appendicitis.
Exactly, Brooke. Fantastic. Appendicitis, pancreatitis, having a metastatic cancer to the liver, right? Or colitis, inflammation of the colon. Also, if we have like post-operative pain, things like chest tubes. Why? Where are chest tubes going?
Your lungs.
And typically, yeah, into that pleural space, right? Abdominal tubes and drains, right? Bladder distension or spasms after surgery, or intestinal distension, like from a paralytic ileus or postoperative constipation, right? All of those are going to be visceral or organ pain. Now, a good way to remember this is if you like words, and I'm a word nerd, the word eviscerated. Have you ever heard that?
I feel like I have, but I don't know where.
I have.
Okay, eviscerated. When you think about eviscerated, think about them opening from the exploding from the inside out. They're eviscerated. Okay, so we're thinking the deepest level from the very inside, their guts, right? Whereas somatic is going to be on the external portion of their body. Okay, the next part is neuropathic pain. So the two major classifications, nociceptive and neuropathic. Let's talk about neuropathic. Neuropathic pain is associated with the dysfunction of the nervous system. So that means that there's some kind of abnormality in the processing of sensations that is different from nociceptive pain. In nociceptive pain, the nervous system is functioning appropriately. There is no abnormality in the processing of sensations, okay? Whereas neuropathic, there is a dysfunction in the nervous system. So medical conditions can cause neuropathic pain. It is more likely that there is a medical condition causing neuropathic pain than a tissue issue causing neuropathic pain. Can you give me an example of a disease process or medical condition that might cause neuropathic pain?
Is this like when someone gets their leg amputated and they have the phantom pain sometimes?
Phantom pain can be neuropathic in nature. Phantom limb pain. Good job. Peyton, can you think of something where they have neuropathic pain? Who has neuropathic
I
pain?
want to say like like some types of cancer, maybe like osteosarcoma, where there's just general pain of, but that would still be the bones.
Yeah, that's going to be more of a somatic pain, so it's gonna be bones and all of those structures. Let's think neuropathy. Who has neuropathy?
Diabetics.
Diabetics, absolutely. Diabetic neuropathy. Why do they have neuropathy? Because the glucose in their blood has damaged their nerve fibers. Remember, we learned about this? And also damaged their blood vessels. And so because there's damage, now their nervous system is not firing correctly, not processing correctly, and they're experiencing neuropathy. Does that make sense? I hope so.
Yes.
Okay,
Yes.
great. Another neuropathic pain, shingles, right? It's coming up through the nerves, okay? Another neuropathic pain, things like trigeminal neuralgia, right? Okay. Aspects of neuropathic pain relate to nursing in several ways. Number one, what does not work for neuropathic pain? We have to
Opioid.
opioids, regular pain medications, opioids, narcotics are not going to work well for neuropathic pain. Why? Because it isn't a tissue injury, right? It is a issue with the way the nervous system is processing. What can we give these patients instead of opioids? If you can just think of one neuropathic medication, that's fine.
Gabapentin.
Gabapentin, perfect. Neurontin is going to treat neuropathic pain. It works on nerve pain, not nociceptive pain. What about things like, so we talked about pregabalin. What is pregabalin? Lyrica, right? That's another one. We can also treat neuropathic pain with antidepressant medications. Isn't that interesting? There is one particular one that they really like. It's called amitriptyline or Elavil. And that antidepressant medication has a way of helping relieve the neuropathic pain. We can also give them NSAIDs. Why? Because if we can reduce the trigger for the neuropathic pain, like swelling, right? Or inflammation, we can
Could we
reduce.
give them non-pharmacological or non-pharmacology whatever? Can we do that? Like for shingles, we can tell them to do like calamine lotion and like
Absolutely, there are more over-the-counter treatments we can give them, and then also non-pharmacological treatments we can give them. We can apply heat, we can apply cold to decrease swelling, right? Acupuncture, acupressure, all of those things are going to help with neuropathic pain because it's an issue with the way the body is sending the signal, right? Okay. 4 phases of nociceptive pain. So we're talking about the pain that is actual pain. There's no issue with the transmission of the signal, right? Transduction begins. The first phase is transduction. It begins when there is tissue damage, and that causes the release of substances that will stimulate those nociceptors and initiate the sensation of pain. So first phase, transduction. The pain happens, the injury happens, and the nociceptors are stimulated, okay? The second phase of nociceptive pain, transmission. That pain sensation is moved from those nociceptors to where?
The spinal cord.
The spinal cord, that's right. So ultimately our goal is to get to the brain, right? To tell the brain that we're in pain. So right now, the transmission phase is where we go from the nociceptors in the area of injury to the spinal cord. Perception is when the pain sensation moves from the spinal cord to the brain. It reaches the brain and the brain says, hey, this is painful, right? So the first phase is transduction. The second phase is transmission. The third phase is perception. And the last phase is called modulation. And this is when the neurons in the brain say, okay, they're in pain, and they send a signal back down the spinal cord by release of neurotransmitters. So, for example, if you are standing in the kitchen and your baby is talking to you and you're distracted and you lay your hand on a hot stove, what would be the example of transduction? Tell me what's happening in the transduction phase.
That would be like when you initially put your hand down and it starts to burn the skin,
Right. So the
but you haven't realized yet.
injury is happening and the nociceptors have picked up on it by being stimulated, but we haven't processed the pain quite yet, right? And this is going to happen in milliseconds because our brain is so wonderful. What is the next phase? Well, those nociceptors are going to tell the spinal cord, hey, she put her hand on the stove, ow, right? And then the spinal cord is going to send that signal to the brain, and your brain is going to go, oh gosh, she did put her hand on the stove. That's not good. That's painful. And then what is your brain going to do during the modulation stage?
That's when you'll start to feel the pain.
You will feel the pain. And what will your brain tell your hand to do?
Take it off the stove.
Move your hand.
Exactly. Move your hand. That's right. Okay, those are the 4 phases of nociceptive pain. Perception of pain. This is so important that we remember. Pain is subjective. That means every person will experience pain differently. And everyone has a different pain threshold. A pain threshold is that point at which the pain is perceived, right? Some people have a high pain threshold. They can handle a lot of pain before they perceive the pain. Some people have a low pain threshold, and very little, minute, what would be just irritating to another person will be very painful for that person. Pain tolerance, however, is different than threshold. It's the length of time or the intensity of pain that a person will endure before outwardly responding to it. So the threshold is when we perceive the pain. So flicking you on the arm might be painful for Peyton, but if I flick Brooke on the arm, she might go, oh my gosh, that hurts so bad, right? That's based on our pain threshold. What do we perceive as pain, right? Pain tolerance is how long can I flick Peyton on the arm before she says, stop, that hurts, or ow. And how long can I flick Brooke on the arm before she says, stop, that hurts, ow, right? How much can you put up with? That's pain tolerance. How much does it take to process it as pain? Pain threshold. Much like spicy foods, right? Everyone has a different spicy food threshold and tolerance. Even though I love to eat spicy wings, I have a very low spicy threshold. I know they're spicy when I'm eating them, right? They taste spicy the entire time, but I can put up with it for a long time because I like the flavor. So I have a low spicy threshold, high spicy tolerance. Whereas my husband, he doesn't even think what I think is spicy is spicy. He says he doesn't even perceive it as spicy. Therefore, he has not only a high spicy threshold, but I would assume if he ended up getting a spicy food that he thought was spicy, he could probably handle it for longer, right? And likely a longer spicy tolerance. The same thing with pain. Does that make sense?
Yes.
Yes.
Any questions about perception of pain before we move forward?
No.
No.
Okay, I'm actually going to take a quick break to show you a video. And I typically start with this video, but I feel like it's a really good video on how our bodies respond to pain. The TED Ed video.
That face that is usually covered by her phone.
Whoop.
Let's say that it would take you 10 minutes to solve this puzzle. How long would it take if you received constant electric shocks to your hands? Longer, right? Because the pain would distract you from the task. Well, maybe not. It depends on how you handle pain. Some people are distracted by pain. It takes them longer to complete a task, and they do it less well. Other people use tasks to distract themselves from pain, and those people actually do the task faster and better when they're in pain than when they're not. Some people can just send their mind a wandering to distract themselves from pain. How can different people be subjected to the exact same painful stimulus and yet experience the pain so differently? And why does this matter? First of all, what is pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Pain is something we experience, so it's best measured by what you say it is. Pain has an intensity. You can describe it on a scale from 0, no pain, to 10, the most pain imaginable. But pain also has a character, like sharp, dull, burning, or aching. What exactly creates these perceptions of pain? Well, when you get hurt, special tissue damage sensing nerve cells, called nociceptors, fire and send signals to the spinal cord and then up to the brain. Processing work gets done by cells called neurons and glia. This is your gray matter. And brain superhighways carry information as electrical impulses from one area to another. This is your white matter. The superhighway that carries pain information from the spinal cord to the brain is our sensing pathway that ends in the cortex, the part of the brain that decides what to do with the pain signal. Another system of interconnected brain cells called the salience network decides what to pay attention to. Since pain can have serious consequences, the pain signal immediately activates the salience network. Now you're paying attention. The brain also responds to the pain and has to cope with these pain signals. So motor pathways are activated to take your hand off a hot stove, for example. But modulation networks are also activated that deliver endorphins and enkephalins, chemicals released when you're in pain or during extreme exercise, creating the runner's high. These chemical systems help regulate and reduce pain. All these networks and pathways work together to create your pain experience, to prevent further tissue damage, and help you to cope with pain. This system is similar for everyone, but the sensitivity and efficacy of these brain circuits determines how much you feel and cope with pain. This is why some people have greater pain than others, and why some develop chronic pain that does not respond to treatment, while others respond well. Variability in pain sensitivities is not so different than all kinds of variability in responses to other stimuli. Like how some people love roller coasters, but other people suffer from terrible motion sickness. Why does it matter that there is variability in our pain brain circuits? Well, there are many treatments for pain, targeting different systems. For mild pain, non-prescription medications can act on cells where the pain signals start. Other stronger pain medicines and anesthetics work by reducing the activity in pain sensing circuits, or boosting our coping system, or endorphins. Some people can cope with pain using methods that involve distraction, relaxation, meditation, yoga, or strategies that can be taught like cognitive behavioral therapy. For some people who suffer from severe chronic pain, that is, pain that doesn't go away months after their injury should have healed, none of the regular treatments work. Traditionally, medical science has been about testing treatments on large groups to determine what would help a majority of patients. But this has usually left out some who didn't benefit from the treatment or experienced side effects. Now, new treatments that directly stimulate or block certain pain-sensing, attention, or modulation networks are being developed, along with ways to tailor them to individual patients, using tools like magnetic resonance imaging to map brain pathways. Figuring out how your brain responds to pain is the key to finding the best treatment for you. That's true personalized medicine.
Do you feel like that video kind of synthesized everything that we talked about so far?
Yeah, I do.
That was a good one.
Do that every time. Start at the beginning. Okay, so physiologic responses to pain. Pain can cause a variety of responses. What do we see in our vital signs?
Increase.
Increases, right? Increases in respiratory rate, increases in pulse, increases in blood pressure. What aspect of blood pressure is usually elevated?
The systolic.
That's right, the top number, the systolic blood pressure. Also, they might be tense, right? Their muscles might be tight. They may sweat. People may flush or be really pale, which are two opposite sides of the spectrum in response to pain. They may frown or grimace or groan or moan, right? Although the presence of any of these factors may indicate that the person is in pain, because they are absent does not prove that there is no pain. So just because they don't have a change in vital signs, or their muscles aren't tense, or they aren't sweating, or they're not pale, or they're not flushed, or they're not fussing, it doesn't mean they're not in pain. Okay? Gonna take a little break here too to talk quickly about people who have substance abuse disorders. So substance abuse problems, how do you think that they affect pain medication in the hospital?
Makes it a lot harder for them to get pain medication or to be believed when they have pain.
Absolutely. Unfortunately, we don't treat people the same that have a substance abuse disorder, and it's wrong, right? We should treat absolutely everyone the same, regardless of their history or their current medical issues. We have to consider,
Did you know
though,
you can go to Liberty?
that folks that have substance abuse disorders may have a lower threshold for pain. So things that aren't very painful for us may be very painful for them. They may also have a lower pain tolerance. So things that we could put up with for a long time, they really struggle to put up with, right? But what is interesting about people with pain, substance abuse disorders, besides the fact that their pain threshold and their endurance for pain may be lower, what do you think is special about them in regards to pain medication?
Their tolerance for pain medication is going to be way offset because of the drugs.
That's right. So they have low pain thresholds, low pain tolerance, but high medication tolerance, right? So the meds are not going to work as effectively for them. So sometimes we find that we have to give them more medication when they're truly experiencing acute pain. Do we ever withhold medications from someone who is experiencing acute pain that has a substance abuse disorder?
If it's acute pain, I would say no.
Right. We are not to deny patients pain medication, even if they have a substance abuse disorder, if they are experiencing acute pain. Okay. What about people that are on pain medicine all the time? Long-term chronic pain medication usage. What do you think about
You can't withhold it because they'll go through withdrawals.
That's
And
right. They're dependent upon the medication. What about when they have like surgery or tremendous trauma, like a motor vehicle accident? What do we have
you'd
to
give
do?
it to them.
We give it to them, but what do we have to think about this, since they're on medication all the time?
Risk of addiction.
Well, they're already going to be dependent probably upon medication. What is their medication tolerance going to look like?
They're going to need more of it.
They're going to need more medication to accomplish the same goal, right? To manage their pain, you're going to have to give them more medication. Okay, that is good. Learning to accept our patients and their pain without judging them, right? Without judging the way that they cope or express their pain or their history with pain or pain medication is a critical process for nurses. We have to work through that. And it's so easy to judge or exclude or have preconceived notions about a patient because of their history with pain, such as they have a history of fibromyalgia and they're always in there for pain and every ache and ouch they complain about and go to the ER for pain meds, right? So they're a chronic pain patient, or their relationship with pain medication. Obviously, they've overused or abused the pain medication for an extended period of time. We have
Like
to,
I burnt my tongue on a cookie.
yeah. Well, that's no good. I'm sorry you both burnt your tongue on a cookie. Okay. Also, we have to remember that our older adults are almost always going to have chronic pain, right? 60 to 75% of them have chronic pain. The most common conditions that cause pain in the elderly, what do you think they are?
Arthritis. Arthritis.
Arthritis, absolutely. Osteoarthritis. Also, like degenerative disc disease. What about like porous bones, right? Osteoporosis, that's a big one. Where do you think they have chronic pain most often besides their joints? So
Their legs.
shoulders, they do have an increased risk of restless leg. What else?
Their backs.
Their
Lower
fingers.
back pain. Yes. Yeah. Fingers are arthritis spots. Absolutely. And they'll also be at risk for increased pain from previous fracture sites. So if they've broken a hip or broken a leg or broken an arm, they'll be ouchy around that area too. Okay.
Especially when it's cold out.
Yes. Yeah. I have seen that as well. Now, if they have diabetes or any other condition with neuropathy, they may also have both nociceptive and neuropathic pain. Okay, so we may have to treat both. This is that pieces of pain theory, right? They have diabetes, and so they have peripheral neuropathy, but they also have osteoarthritis and bilateral hip pain. We're going to have to treat them with both a neuropathic pain medication like gabapentin or pregabalin, and also a medication that targets those nociceptive areas or somatic or visceral tissues, right? Things like opioids or over-the-counter NSAIDs or Tylenol, right? Okay, aspirin, things like that. Let's watch this video on pain quickly. It's another great TED Ed video.
LibertyMutual.com to customize your car insurance so you only pay for what you need?
Really?
This one is just going to further explain pain and how it works.
In 1995, the British Medical Journal published an astonishing report about a 29-year-old builder. He accidentally jumped onto a 15-centimeter nail, which pierced straight through his steel-toed boot. He was in such agonizing pain that even the smallest movement was unbearable. But when the doctors took off his boot, they faced a surprising sight. The nail had never touched his foot at all. For hundreds of years, scientists thought that pain was a direct response to damage. By that logic, the more severe an injury is, the more pain it should cause. But as we've learned more about the science of pain, we've discovered that pain and tissue damage don't always go hand in hand, even when the body's threat signaling mechanisms are fully functioning. We're capable of experiencing severe pain out of proportion to an actual injury, and even pain without any injury, like the builder, or the well-documented cases of male partners of pregnant women experiencing pain during the pregnancy or labor. What's going on here? There are actually two phenomena at play: the experience of pain and a biological process called nociception. Nociception is part of the nervous system's protective response to harmful or potentially harmful stimuli. Sensors in specialized nerve endings detect mechanical, thermal, and chemical threats. If enough sensors are activated, electrical signals shoot up the nerve to the spine and onto the brain. The brain weighs the importance of these signals and produces pain if it decides the body needs protection. Typically, pain helps the body avoid further injury or damage, but there are a whole set of factors besides nociception that can influence the experience of pain and make pain less useful. First, there are biological factors that amplify nociceptive signals to the brain. If nerve fibers are activated repeatedly, the brain may decide they need to be more sensitive to adequately protect the body from threats. More stress sensors can be added to nerve fibers until they become so sensitive that even light touches to the skin spark intense electrical signals. In other cases, nerves adapt to send signals more efficiently, amplifying the message. These forms of amplification are most common in people experiencing chronic pain, which is defined as pain lasting more than 3 months. When the nervous system is nudged into an ongoing state of high alert, pain can outlast physical injury. This creates a vicious cycle in which the longer pain persists, the more difficult it becomes to reverse. Psychological factors clearly play a role in pain too, potentially by influencing nociception and by influencing the brain directly. A person's emotional state, memories, beliefs about pain, and expectations about treatment can all influence how much pain they experience. In one study, children who reported believing that they had no control over pain actually experienced more intense pain than those who believed they had some control. Features of the environment matter too. In one experiment, volunteers with a cold rod placed on the back reported feeling more pain when they were shown a red light than a blue one, even though the rod was the same temperature each time. Finally, social factors like the availability of family support can affect perception of pain. All of this means that a multi-pronged approach to pain treatment that includes pain specialists, physical therapists, clinical psychologists, nurses, and other healthcare professionals is often most effective. We're only beginning to uncover the mechanisms behind the experience of pain, but there are some promising areas of research. Until recently, we thought the glial cells surrounding neurons were just support structures, but now we know they have a huge role in influencing nociception. Studies have shown that disabling certain brain circuits in the amygdala can eliminate pain in rats, and genetic testing in people with rare disorders that prevent them from feeling pain have pinpointed several other possible targets for drugs, and perhaps eventually gene therapy. Ever wonder how pain relievers work, or how other animals experience pain?
Okay, isn't that interesting? I think that that was a very good argument for why it's important that we treat pain from all aspects and get everyone involved in the plan of care when we have a patient experiencing pain. Cultural considerations for pain. A person's cultural background may influence their feelings about pain. In much of Western culture, it's considered valuable to have a high pain tolerance, right? Especially the macho men, right? Macho men can do a lot, they can take it, right? Other cultures, however, promote the idea that to endure pain is natural or honorable. To go through the pain process, it's a normal thing, and you're great for doing it, right? Learning ways to accept without judgment. This is what we just talked about. The various ways of coping with the pain and expressing the pain is a necessary process for nurses. A nurse's cultural background over here approves the stiff upper lip approach to handling pain, right? Like, oh, I bet they're just drug seeking, right? Or, wow, that hurts him that bad. That's a 10 out of 10, really? All of those people may have issues, excuse me, all of those nurses that come from that kind of background may have issues treating their patient's pain effectively because they're not able to see their patient as a person going through the subjective experience of pain. And that pain may be differently perceived for the patient than it is for the nurse. And just because there's no outward expression like that change in vital signs or the grimace or groan, etc., doesn't mean that the patient is not in pain. Okay. Patients whose cultural upbringing would cause them to hide or deny the pain may sit there and sit there and sit there, right? Hurting terribly, but refusing to ask for pain medication, you know? And so until the nurse says to them, hey, you really should probably think about taking something, it would be a really good idea to get some pain medication on board. You know, there's nothing wrong with having a little bit of ibuprofen. It might help reduce swelling, doing some good education about the pain medication and encouraging them to take their medication and understand how how their pain medication will help them heal. Encouraging them to get up, right? It's going to help them maybe be more accepting of the pain medication. In the same respect, if they are not, they're really not receptive to pain medication, they don't want anything to do with it, you do have to respect their culture and beliefs, or their preferences. Acute pain versus chronic pain. Acute pain usually usually has a known cause, whereas chronic pain may be idiopathic. We don't know what's causing it, or it may be a huge conglomeration of issues. It may be resulting from central sensitivity syndrome, where we created more of those nerve cells and a heightened response to stimulus. It may be a neuromatrix issue. Acute pain can last hours to days, right? Potentially even weeks. But chronic pain, what was that magic number? They have to have pain for how long before it's chronic pain?
3 months.
3 months, that's right. Surgical procedures, burns, sprained ankles, tissue trauma injuries are going to cause acute pain. Remember that pain is a stressor on the body. It's going to take energy for the patient to manage the pain. So chronic pain patients are going to be could be depressed and fatigued because they're constantly using energy, not just emotionally and psychologically, but bodily energy to manage their pain. Prognosis. With acute pain, we have a good prognosis. These people usually recover well. That pain may resolve spontaneously or after we give medications or do other kinds of therapeutic interventions. Chronic pain actually has a poor prognosis because the complicating factors, whatever's going on to cause the chronic pain, is hard to remove. Something like a disease process or an idiopathic issue or an underlying pathology that we can't get rid of, right? Spontaneous relief of chronic pain is very unusual. Causes of acute pain, relatively easy to identify, but causes of chronic pain can sometimes be tough. We talked about that. Sometimes that diagnosis can be complex or we don't ever figure out what's causing the pain. Psychosocial effects. Acute pain, if they have any psychosocial effects at all, it's usually really quick. They don't last long. It may temporarily disrupt their life, right? You know, having a broken arm or burning their hand on the stove. They might not be able to wash the dishes for a few days, right? But it's not going to severely impact their life. Whereas chronic pain can affect a person's ability to earn a living, enjoy social activities, and have good self-esteem. It may impact all areas of their life as they isolate themselves, reduce their activity, and don't participate in normal activities of daily living. Effective therapy on acute pain. Medication is very beneficial with acute pain, especially with surgery. We can do a surgery, remove whatever's causing the acute pain. Like if it's a broken arm, we can reduce the break, right? Put a bit of cast, give them some pain medication, and we did a great job, right? The pain is usually well relieved. With chronic pain, sometimes medications can help, but the patient does often become dependent upon the medication, okay? Multiple medication may be required, especially if they have both neuropathic and nociceptive pain, and surgery could help the problem, but it could also worsen the problem, especially if it's some kind of neuropathic pain. Important to note, in general, when we give people pain medication for acute pain, only 1% of those receiving pain medications, like narcotics, will become dependent. It's this huge idea that everyone who receives pain medications will become addicted, right? We need to put that in check. Yes, it's real. Yes, it's actual. However, the actual statistic is 1% of those receiving those narcotics will become addicted. Pain rating scales. So we have numbered scales. This is the 0 to 10, right? We have visual scales. This is where we have like an image, and on our image, we have some kind of either drawings of faces that progress through a series of expressions, like going from happy and smiling to crying. We also have color scales where it goes from red to blue, right? And they can pick the color that best represents their pain. Also, we talked about the pieces of pain where we put out the poker chips or those other identical plain objects in front of them, right? And they have to select the number of chips that equals how much pain they're experiencing or how many areas they have pain. Behavioral pain scale. So this is like the FLAC scale. We'll talk a little bit more about that in a second. We use the FLAC scale, and FLAC is an acronym for face, legs, activity, cry, consolability for newborns very often. So we're going to look and see how the baby is responding to pain. We also can use this for the cognitively impaired. So here's that Wong-Baker Faces scale. So you can always substitute numbers 0, oops, get that plugged in, 0, 2, 4, 6, 8, 10, right? And so you have the child typically, or the cognitively impaired person, pick the face that best represents their pain. Here is the FLAC scale. Peyton, would you very quickly please read the description of each level of the FLAC scale? So start by doing face. A 0 means no particular expression or smile. A1 means an occasional grimace or frown, withdrawn, disinterested. A 2 means frequent to constant frown with a clenched jaw and quivering chin.
Legs, 0, normal position or relaxed. 1, uneasy, restless, tense. 2, kicking or legs drawn up. Activity, 0, lying quietly, normal position, moves easily. 1, squirming, shifting back and forth, tense. 2, arched, rigid, or jerking. Cry, 0, no cry, awake or asleep. 1, moans or whimpers, occasional complaint. 2, cries steadily, screams or sobs, frequent complaints. Consolability, 0, content relaxed. 1, reassured by occasional touching, hugging, talking. 2, distractible. 2, difficult to console or comfort.
Okay. Data collection difficulties. They have a language barrier. They can't talk or they don't speak English, right? It may be an issue. English second language, you bring in the MARDI. Cultural considerations, pain expression, and what does pain mean for the patient? What are the patient's preferences in regard to pain? What action does the patient desire be taken in response to pain? Referred pain, heart pain. It's difficult to identify where the pain's coming from when they complain of a stomach ache or a tingling arm or a painful arm, right? And then the outward appearance of pain. Men, especially white European men, display the strong stoicism. So they're stoic, right? They try to not let you know they're in pain. Narcotic use brings fear of addiction for many patients. The patient may dismiss the effects of pain and continue to work and carry out usual activities. They also may decrease the use of pain medication quickly. Oftentimes, the Caucasian American or European patient prefers to use non-narcotic medications. They prefer to use relaxation or distraction techniques instead of medication, or just to tough it out. Hispanic or Mexican Americans. Hispanic Americans often believe that pain is God's will. Many are Catholic, and they believe that it's just a process of natural, endurance, and they're very stoic. They don't let you know that they're in pain. Their pain may also be seen as a consequence of immoral behavior in their culture. For some men, expressing pain would show weakness and may cause a lack of respect within their sociocultural groups. Other Hispanic groups are very expressive of pain and discomfort. They may groan, they may moan, they may cry, and that expression may be seen as acceptable. Many believe that IV medication is better treatment than pill, right? Prayer, heat, or herbs may be used within their sociocultural norms to treat pain. Black, so your African American or African Native patients often see pain as a sign of sickness, right? They may express pain openly, but it just kind of varies depending on their culture. Pain may be seen as something that just needs to be endured. They may do laying on of hands and prayer to relieve pain. They may rely on spiritual or religious beliefs to help endure the pain. And then Asian populations. It varies among the subgroups, but generally they don't talk much about pain. They bear with the pain as a matter of family honor. They may describe pain very obliquely in terms of what symptoms their body's experiencing. And then Filipinos may view pain as a part of life to endure, and it is very honorable to get through the pain. Older adults may fear addiction to pain medication. Asian populations may also prefer oral or IV pain medication. Injections like injectable medications, IM, sub-Q, may be seen as too invasive because of privacy. They may use applications of moist heat, and the family may request pain medication for the patient. American Indian or Native American patients may believe that pain is something to be endured and may not ask for pain medication. Pain may be described as general body terms, like, oh, I just really don't feel good. They may not be aware that they can ask for pain medication. And many Native Americans rely on traditional medicine and herbal preparations to treat pain. They may tell their family or visitors about their pain, then tell their healthcare provider. Arab populations may view pain as something to be controlled and expect very prompt treatment for their pain. They may describe their pain in terms of being hot or cold. They may express their pain more openly to family than to the healthcare providers. Here's a question for you. In determining the patient's perception of pain, which question would be useful in assessing pain? And you do have a cheat sheet, so I will go ahead and tell you if that's okay. The question we could ask them are, where are you hurting? What pain control measures have worked for you in the past? How would you describe your pain? And what were you doing before the pain started? Prevent complications. Prominent documentation of any known drug allergies. It's very important we get drug allergies. We ask before we give medications, right, about drug allergies, that we record pertinent information that we get during our assessment, what meds they're on, how they've experienced pain in the past, what pain meds work well for them, etc. That the patient and family teaching is done, that we talked about the dose of the medication, how often they take it, and when they need to call their doctor. Also, that we monitor for side effects and that we tell the doctor if anything is not working well for them or if there's any problem or issue. That we accurately and completely document any adverse reactions to treatment, and we communicate all of that information to the other members of the team, to the patient, and to their support. We need to accurately document about pain, the location, the intensity, the duration, how we assessed it, what aggravates it, what makes it better, right? What measures we did to make it better, whether they be analgesic or adjunctive. If it's non-pharmacologic, we need to put it in there too. An evaluation of how effective our measure was, that we notified the doctor if there was a problem, right? And what the physician decided to do. And that we taught the patient and the family about pain or pain medication, etc. Whatever education we did, that we documented it. If you don't document it, you didn't do it, right? When we're assessing pain, we need to remember the acronym. It's an alphabetic acronym, OPQRST. O stands for onset. When did the pain start? P stands for provocation or precipitating factors. What caused the pain? Q stands for quality. Tell me about your pain. How often does it happen? Is it aching? Is it stabbing? Is it shooting? R stands for radiation. Does it go anywhere? Does it move to your back? Does it move to your arm? S stands for severity. Is it, how would you rate it? 0 to 10. Would you say that it's severe or moderate or mild? And then T stands for time. How long have you been in pain? How long have you experienced this? Effective pain management is not just a matter of giving the right medicine at the right time. It is a combination of pharmacologic, non-pharmacologic approaches and getting everyone on board in the healthcare team like we saw in the video, right? To get the best amount of comfort for the longest amount of time for the patient. Pharmacologic approaches. We can give oral pain meds, IM injections, sub-Q pain medicines, topical pain medicines, transdermal patches, buccal swabs like Oragel, IV analgesics, patient-controlled analgesia or PCA pumps, epidural pain medicines, or peripheral nerve catheters. Non-analgesic pharmacological pain control, antidepressants like the amitriptyline for neuropathy, chemotherapeutic agents, immunosuppressants, anticonvulsants, muscle relaxants, marijuana. All of these can be used to reduce pain, and they're not technically pain medications. Special considerations in pain management. Aspirin will thin the blood. So what do we have to worry about? What do we need to emphasize with this patient?
Fall risk.
Fall risk. We need to emphasize safety, right? If they fall, they may bleed. Acetaminophen may also cause issues with the liver, right? So we need to look at their liver labs before we give them IV acetaminophen, which is called Ofirmev, or if we give them if we got them on Tylenol around the clock, make sure that their liver's okay, that they don't have a diagnosis of cirrhosis or hepatitis. NSAIDs can affect what? The GI system, right? Also the renal system. So we need to make sure, especially in the elderly who are at increased risk for GI and renal susceptibility to NSAIDs, that we're being careful, right? That we're looking at their labs. Nursing responsibilities. You do all of the rights of medication administration, all 6, right? Can somebody name all 6 real quick?
Right patient, right route, right dose, right time,
Right drug,
right drug, and there's one more. Right route. Did I say route?
Right.
Right.
Right reason?
right documentation, that you're actually getting it put into the chart. Okay, side effects of medication, especially narcotics, right? Morphine, meperidine, codeine, what are they gonna do? They're gonna cause constipation. We can give the patients fluid and fiber because it's gonna slow peristalsis, or the contraction and relaxation of the intestines, right? We increase oral fluids. We give them stool softeners. Fiber-based laxatives, things like Metamucil. We can also give them Miralax if we want. Drowsiness and euphoria, right? We give them pain medications. They may be kind of loopy-goofy or sleepy. Itching and hives, that's an allergic reaction potential, right? We need to report that and discontinue the med immediately. Get something else. We may give something like Benadryl or epinephrine, depending on how bad it is. Respiratory depression. Whenever we give things like morphine, Dilaudid, fentanyl, we always have that side effect of suppressing the respiratory system. Obviously, we're going to resuscitate the patient immediately. We'll provide respiratory support. Call the code team. If we're at home, we'll call the physician's office, and we'll definitely call 911, right? Provide respiratory support. Or excuse me, first thing we would do would call 911 if we're in home or physician's office or clinic, and then we provide respiratory support to the patient. Also, Narcan, naloxone, can be given to reverse the effects of narcotics. It can be given IM, it can be given IV, it can also be given intranasally. And then addiction to narcotics is a possibility, but in reality, almost it never occurs when pain medications are taken for actual real pain. Patients in pain do have a right to get medication and have it available to them. They could become dependent if they're on long-term use of narcotics. They should never stop them immediately or abruptly because they are maybe dependent on it and go through withdrawal. Pain can be controlled with non-narcotic medications, and the patient can be tapered off of the narcotics, okay? 1% of folks actually become addicted to narcotics. End of life pain medication. There's no scientific evidence that's proven that opioids can hasten death when given correctly to control pain. However, we have seen things like the Mount Carmel cases where they've given excessive amounts of medication. A normal dose of fentanyl is somewhere between 50 and 200 mics, right? Micrograms. 50, 100, 150, maybe even 200. That's a big honking dose of fentanyl. This particular doctor was giving 1,500 micrograms, 2,000 micrograms, 10 times the normal dose to patients who were actively, they weren't actively dying, but they were near death, right? They were on ventilators. They were in comatose states or vegetative states. And that hastened death for them because it was administered for the purpose of hastening death, not the purpose of relieving pain. Of course, we do have a moral obligation to our patients to make sure that they are treated for pain, even at the end of life, but we don't want to expedite that movement towards end of life. Non-pharmacologic approaches: sleep, heat, cold, menthol, distraction, relaxation, guided imagery, meditation, hypnosis, biofeedback, music, binders like abdominal binders, massage, acupuncture and pressure, TENS units, and spinal cord stimulators. Invasive treatments, sympathectomies. This is where they're actually going to go in and remove parts of the sympathetic nervous system that are firing. Rhizotomies and cordotomies. We're going to learn a little bit more about these in just a second. Complementary and alternative therapies for pain relief. Complementary and alternative therapies are used for pain relief more than anything else. Therapies used include relaxation, meditation, biofeedback, yoga, hypnosis, imagery, chiropractic care, etc. Research from NIH has proven that acupuncture has been very effective for pain. Which statements by the nurse promotes the use of massage in reducing pain? Family members can perform it safely and effectively. It stimulates the circulation in reddened areas. It relaxes muscles. It increases the general sense of well-being, or it uses short, mild strokes. Select all that apply. You got your cheat sheet up in the upper right corner if you're struggling.
Looks like, I think 1, 3, and 4.
Involved, they can do it. It does relax the muscles and it can increase the general sense of well-being. Okay, nursing responsibilities. Get them involved with a social worker if they have chronic pain. Teach them on complementary therapies. Make sure that in extended care, they're getting adequate pain management so that they can rest and rehab, right? At home, make sure you're doing great discharge teaching, giving them good resources. Consider other alternatives to pain medication, such as heat and ice application, rest, distraction, things they can do. Involve the family. They may go home with a sub-Q PCA. And make sure that we know the role of the LPN and the LVN in this, right? That they can, if they're IV certified, they can go out to their houses and give them IV pain medications through like a bag, right? Now, in our state, we can't do PCAs. So we can't do patient-controlled analgesics. We also can't do IV pushes, right? So just know the scope and the role of the LPN within the state of Ohio. Okay, let us see. I do have a really great video on phantom limb pain. I think I'll upload that into the course if you're interested. And also pain and cognitive impairment. We need to be very careful. Just because the patient doesn't say they're in pain doesn't mean that they're not in pain, right? And as the elderly get more advanced in dementia, for example, they may not be able to express the pain any longer. So when mom was 82 and alert and oriented ×4, she complained all the time about her hip pain. But now that she's 84 and she has advanced dementia, she doesn't complain about her hip pain anymore. Do you think her hip pain went away?
No.
No, it didn't. It didn't go away. She's just not able to express it as effectively. So it's important to realize that that is a potential. Okay, we have 2 quick games. We're going to run over just a little bit today. I apologize. I will try to make the most effective use of your time. Okay, here we go. We're going to play Who Wants to Be a Millionaire? The physician has prescribed non-steroidal anti-inflammatory meds to manage the patient's pain. Based on your knowledge, how does this classification of drugs work? A, the medication interrupts the transmission of pain. B, the medication blocks neurotransmitter uptake. C, the medication blocks the production of nociceptor triggers. Or D, the medication reduces the body's perception of pain.
D.
That's the one part of
Is
this
it-
job I don't like at all. Boy,
Is it C?
It is in fact C, because when we give NSAIDs, we're going to reduce swelling and other inflammation and inflammatory and aggravating factors that may produce the triggering of those nociceptors, right? Or the stimulation of those nociceptors. A postoperative patient is complaining of discomfort at the incision site. What term can best be used to describe this type of pain? Intractable, somatic, visceral, or neuropathic?
Somatic?
Somatic is correct because it's at the skin and subcutaneous level, right? It has to do with muscles, bones, etc. The nurse is planning a teaching session to discuss the occurrence and management of phantom pain. Which manifestation is characteristic of the phenomenon? Aching, poorly localized fiery pain, cramping, stabbing pain, or dull pain?
Is it dull pain or aching? It's either A
Dull
or
or
B.
aching. I don't know between those two.
I don't either.
Do you want to use your 50-50?
Yeah.
I'm
Yes.
going to eliminate aching and dull for you.
Okay, then I think it's poorly localized fiery.
Okay. It is in fact poorly localized and fiery. Okay, it's obviously related to a limb that's not there, right? So they're not able to say this is exactly where the pain is. And it's fiery, it's a burning pain when they have phantom limb pain. And you'll see that in that. Sorry, my slides are so loud. You will see that in the video that I post within the group about phantom limb pain, okay? What is the correct order of events when a painful stimulus is experienced and detected by the body? Transduction, transmission, perception, modulation, perception, transduction, modulation, transmission, transduction, modulation, perception, transmission, or modulation, transduction, transmission, perception. This is the 4 stages of perceptive pain.
It's A.
A.
It is A, fantastic. Traditional beliefs by Hispanics concerning the perception of pain include that pain is seen as a sign of weakness, something that must be endured, God's will, or something that must be controlled.
B.
Do you want to use either of your other lifelines?
I'm gonna take it. It's not B. I'm just kidding.
You have asked the audience, AKA me, or phone a friend, AKA me.
Let's ask the audience.
Okay, audience thinks 80% of them say it's C, 20% of them say it's D.
I'm gonna go with C.
Yes, traditional belief of Hispanics is that pain is God's will. And this is statistical, almost sounds stereotypical, right? However, it is a correlation that you need to be aware of to be more culturally sensitive. And it is something that is taught within our book. So that is why I have to relay that information to you. It is testable information, okay? Which culture has traditionally recognized the use of medicine men? Europeans, Arabs, American Indians, or Hispanics?
C.
C is correct. Well, you've made it to the $10,000 mark. Let's see if we can do this. Here we go. When discussing pain control measures regarding older patients with a group of new nurses, which statement by a new nurse should the charge nurse address? A, older patients may view pain as a normal part of aging. B, older patients may deny pain because they attribute it to aging. C, older patients might not report pain out of concern for the cost of test or treatment related to obtaining diagnosis. Or D, older pains have a higher pain tolerance. We're looking for the statement that the new nurse would say that would make the charge nurse concerned.
I would
Oh.
say D because I don't think they have a higher.
No,
pain
they
tolerance.
don't. They shouldn't.
D is correct. The nurse is collecting data from a patient concerning the patient's abdominal pain. Which statement or question by the nurse would be most useful? Does it hurt badly? How long have you had this pain? Do you have a high pain tolerance? Or I bet this is really bad.
B.
B is correct. It's going to be the T aspect of your OPQRST assessment. Which commonly held perception about pain is false? Newborns are too immature to perceive pain. Pain tolerance is a physiologic response to pain. Pain can be present even though no cause is found, or fewer than 1% of patients become addicted to drugs used to relieve acute pain.
Is it A?
It is A. Great job, Brooke. Your $50,000 question. You've got a lot on the line, guys. Medications placed on a specific area of the skin for absorption into the vascular system are best described as what? Buccal swabs, transdermal patches, peripheral nerve catheters, or topical analgesics.
Patches?
I think it's topical analgesics because it says medications placed on the skin.
That is correct. But I could see where transdermal patches would make you think. You've got to really read into these questions sometimes. 100,000. A client with chronic pain reports to you, the charge nurse, that the nurse has not been responding to requests for pain medication. What is your initial action? Have a conference with the nurses responsible for the care of the client. Ask the nurse educator to give an in-service on pain management. Check the MARS and nurses' notes for the past several days, or perform a complete pain assessment and history on the client.
I want to say C because maybe the MAR or the nurse's notes have reason for holding why they held the medication.
It's a very good argument. However, that is not your initial action.
So your initial action, I think, would be D because assessment is the first part of the nursing process.
That makes sense, but that's actually not your
Is
initial
it
action
B?
either. It is not B either.
What?
It is
Well, it's
A.
got to be A.
Oh,
What
gosh.
you're going to do is talk to the nurses. Hey, Mr. Johnson says that you've not been giving him his pain medication. What's happening? Right? As charge nurse, it's your responsibility to meet with your nurses to determine their attitudes and their effectiveness as nurses, their practice as nurses, right? So figure out what's going on. They may tell you, oh, I've given him his medication every single day. He's always like that. He has dementia. And then you could perform a history on the client and check the MAR and see that, yes, she's given his meds. And in fact, he does have dementia. And there's notes in there about him saying things that aren't necessarily true. You could realize after talking to your nurses, oh, he said it was a 10 out of 10, but he didn't really look like it, so I didn't give it to him. And then you would realize it was a knowledge deficit, and you may ask your nurse educator to give an in-service, right? Or your nurse would be like, I don't know what he's talking about. I gave him his meds. I give all my patients their meds. And they would be kind of sneaky and suspicious. And you may want to check the MAR, make sure that the meds were actually administered and the nurse's notes reflected what was given, right? So your primary action is to talk to the nurses. Family members are encouraging your client to tough it out instead of run the risk of becoming addicted to narcotics. The client is stoically abiding by the family's wishes. Priority nursing interventions for this client should target which dimension of pain? Behavioral, sociocultural, interpersonal, or psychosomatic? It's going to be sociocultural. And I think that's supposed to be socio. Yeah, there it is. Sociocultural. Because it was common in that culture for them to be stoic, right? So there's some sociocultural component to that response. A client with diabetic neuropathy reports a burning electrical type in the pain in the lower extremities that's not responding to incense. You anticipate that the physician will order which adjuvant medication for this type of pain? What additional medication? Hydrocodone acetaminophen, which is Norco or Vicodin, amitriptyline, which is Elavil, methylprednisolone, which is Solumadrol, or lorazepam, which is Ativan.
Well, I know C
Amitriptyline.
was on our exam.
C was on your exam. It decreases inflammation, right?
I
So
think
this
it's B.
It is B because this antidepressant Elavil can treat neuropathy or neuropathic pain. This is your $1 million question. Which client is most likely to receive opioids for an extended period of time? A client with fibromyalgia, a client with phantom limb pain, a client with trigeminal neuralgia, or a client with progressive pancreatic cancer?
Pancreatic cancer.
Yep, I agree. Cancer.
Yes. So fibromyalgia may be on opioids for a long period of time, but who is most likely, right? Definitely our terminal illness or our aggressive cancer. You won $1 million. Congratulations.
I feel like that was real life.
Okay. Okay, the last thing we're going to do is a case study with 10 questions today, okay? And then I have another video I do want you to watch. So I'm uploading both of these videos. I may end up just uploading the entire list here, but I want you guys to focus on the phantom limb pain. And then also this one's very important, racial disparity and pain. Statistics show that we under-medicate or we as nursing professionals, healthcare professionals do not take seriously or as seriously the pain of women versus men and the pain of African Americans over all other races. So we need to be aware. Why? So that our practice can be an informed practice, right? So I'm going to upload these videos and I am very strongly encouraging you to watch them. There also will be questions on your exam and your quiz that are covered within the context of these videos. And then 7 and 8 is an example of I should say OP, but they don't do an onset question. An assessment of pain, a good one, and then one with some errors for you to compare, okay? Let's get into this case study. Pain case study for chapter 7. Helen Gordon is an 80-year-old resident in a long-term care facility. She suffers from chronic illnesses, including chronic renal failure, hypertension, osteoporosis, and osteoarthritis, a progressive degenerative joint disease that affects several of the patient's joints, particularly her knees. Until recently, she was able to walk using a walker. But during the past week, Ms. Gordon has frequently reported pain. She relies on a wheelchair to get around, and she requires moderate assistance with transfers. So we're going to have 10 questions relating to her care and information about her case study. I want you to read the question and then the answers and select the choice, and we'll take turns. Brooke, can you go first, please?
Would it be ask the patient to D?
So the question is, what is the first action of the nurse toward managing the patient's pain? Provide relaxation techniques, administer whatever pain medication is ordered, conduct a thorough pain assessment, or ask the patient to rate the intensity of the pain. You think it's ask the patient to rate the intensity? First action when addressing this patient's pain, Mrs. Gordon's pain.
Would it be C?
Yes.
Because a pain assessment would contain the intensity of the pain.
It would, in fact, and we want to know what is going on. When did it start? What makes it better? How long have you been in pain? Let's go through OP. When did it start? What happened to bring it on? What were the precipitating factors, right? What is the quality of the pain? Tell me, does it ache? Is it sharp? Is it stabbing? Does it radiate anywhere? S, what is S, guys? Severity. So that is your intensity, right? Rate it 0 to 10 for me. And then time. How long have you been experiencing the pain? Which of the following would not be a basic part of the pain assessment? Peyton, can you read the answers and select the correct one?
A, location of pain. B, factors that exacerbate and alleviate the pain. C, vital signs. Or D, intensity of pain. And I believe it is C, vital signs.
That is correct. It is C, vital signs. 3, Ms. Gordon states the pain is worse in her knees and describes it as an ache. She denies having any burning, any numbness, any tingling or shooting pain. The quality of the pain she describes is indicative of what kind of pain, Brooke?
I want to say C, A, and B.
Okay, she's missing a limb.
Oh,
I think it's A because she's not missing a limb. Not that I heard.
She does not have any burning, does not have any numbness, no tingling or shooting,
it's
but she's
phantom
got
pain, isn't it?
aching knees. Aching knees. Remember where osteoarthritis falls in our types of pain? What kind of pain is it? Osteoarthritis. It's a cutaneous or superficial somatic pain, right? Deep somatic pain is also bone, muscle, connective tissues. So that's osteoarthritis. Somatic pain is a type of nociceptive pain. Miss Gordon rates the intensity of the pain as 7 on a scale of 0 to 10. She states it is continuous and increases with weight bearing. The only pain medication ordered for her is Tylenol, which is no longer effectively relieving the pain. An appropriate class of med to consider adding for pain medicine is what? Pain management is what? What should we add?
Instead,
NSAIDs, absolutely, to decrease the inflammation, right? Number 5, Ms. Gordon's physician orders an additional medication. Which of the following is the most appropriate choice? So in addition to your NSAID, are we going to give a fentanyl patch because the pain is continuous and the patch is long acting? Are we going to give an IM injection of morphine because it's quick acting? Are we going to give oral Percocet, oxycodone on and around the clock basis? Or are we going to give gabapentin for neuropathy? Excuse me.
I almost think a fentanyl patch because it's long acting.
And I could see where you would think that. However, you're going to give the oral oxycodone all around the clock, okay? It's an opioid. It's going to help to reduce her perception of pain, right? Much as fentanyl would. However, fentanyl is a lot stronger of a drug, and the patch is long acting, but it's not something that we can like take off and put back on if necessary. You know what I mean?
Yes.
Oxycodone, you know, if she's feeling really good, and even though it's prescribed around the clock, if she talks to her doctor, she could skip a dose, or if we could adjust it, right? You would also expect an order for which of the following class of medication to accompany the opiate: laxative, antibiotic, stool softener, proton pump inhibitor.
Stool softener.
That's right. Why? What's the rationale for that?
Opioids cause constipation.
That's right. Which of the following is not a principle of pain management in an older adult? Several pain-producing conditions sometimes coexist. There is an increased risk for gastric and renal toxicity with NSAIDs. Pain is a normal process of aging, or older adults are often fearful that pain will result in a loss of independence, making them a burden on their family.
C.
Pain is a normal part of aging, and there is an increased risk for gastric and renal toxicity.
Thought
And
it said not. Sorry.
oh, that's okay. No worries. Older adults are not often fearful that pain will result in a loss of independence. I mean, excuse me, they are often fearful. However, this is not one of those principles of pain management that we need to really consider, when thinking about managing the pain of the older adult. We want to consider that they may have multiple conditions we have to treat, that consider their the effect of medications and their side effects, and then realize that pain is a normal part of aging for them. To evaluate the effectiveness of the pain medication, what action should the nurse take? Ask the patient if the expectations for pain relief were met. Check to see if the patient is sleeping after the medication takes effect. Reassess the patient's pain, including asking about its intensity. Or D, A and C.
C. Actually, A and C.
I think it's A and C.
C. Did we meet your goal? Did we meet the goal? Do you feel better? Are your expectations met for pain relief? And then reassess with the full OPQRST evaluation. Which of the following is not a non-pharmacologic intervention for pain? Relaxation techniques, acupuncture, a PCA infusion, or heat and cold application?
C.
C.
C, right, because it is pain medication, just controlled by the patient. And the last question for you guys, and we will be done with our lecture for today. Ms. Gordon has had this pain for several months, which makes her less sensitive to the pain experience. True or false?
I think it's false because I remember in the video it talked about if you have pain for a long time, then your brain sends signals to make it more sensitive to protect the body.
Absolutely. Fantastic in bringing the video into application to the question. You're right. It is false. It in fact can make them more sensitive to the pain experience. Okay, guys, I hope you have a fabulous day. I will be uploading the Chapter 7 videos momentarily for your review. So please be sure to review those.